All right, we can get started. Welcome, everyone. I'm Sylvia Balbo, and as the co-leader of the Carcinogenesis and Chemoprevention Program here at the Masonic Cancer Center, it's my pleasure today to introduce one of our members and a collaborator, Alex Khoruts. He's a professor of medicine in the Division of Gastroenterology, Pathology, and Nutrition, and he's the director of the University of Minnesota Microbiota Therapeutics Program. Despite not being born here, I would say that Alex is a true Minnesotan since he has done most of his training here at the U, where he completed his fellowship in gastroenterology, but he also trained in basic immunology as a Howard Hughes Physician's Fellow under the mentorship of Mark Jenkins in the Department of Microbiology. And so out of the combination of skills that Alex has achieved or has acquired here, he pioneered fecal microbial transplants and became a world reference in microbiota therapeutics. And today is here to tell us a bit about his journey in this field, all starting from one specific difficile case back in 2008. So Alex, thank you.
Thanks, Sylvia. Apologize a little bit about my voice. I got hit by RSV last week earlier. So you can get a vaccine for it if you're over 60. And I just turned 60. It's like, I'm not joining that club yet. So the message of this talk, vaccines work. All right. So as I said, this is a bit of a journey overview because it's a new field. And we have some IP, and that's a separate story, which could be just as interesting, but a different department. So the index case was back in 2008. That's how I ultimately switched my entire research focus from T-cell biology and basic questions of T-cell homeostasis and Treg biology to something completely different, which at the time seemed this is much bigger than Tregs, and actually, perhaps it is. So this was a clinical case. The patient was a 61-year-old woman. She had, when she came to clinic, she had a history already of 8 months of diarrhea. It was quite profound. She was basically in a wheelchair, having bowel movements every 15 minutes around the clock, 24/7. Had a number of hospitalizations. The whole thing started with some antibiotics for pneumonia and urinary tract infection. And then periodically she would get hospitalized and get more antibiotics. Over this time, she lost about 60 pounds of weight. And basically this clinic stop was her last stop. And the thought immediately came to mind, well, her microbiome is completely destroyed and is probably at the core of this. In fact, we did a flexible sigmoidoscopy, looked inside the colon right in the office, and what she had was called pseudomembranous colitis. It's very characteristic appearance. It's actually very interesting. You see these adherent plaques of pus made of neutrophils, but actually these are largely composed of nets, neutrophil extracellular traps. So when there's a break in the gut barrier, the neutrophils come out and they spill their guts, and that establishes a mesh to trap microbes from coming through. So it's kind of a temporary bridge. It's also a sign of very severe disease. So the diagnosis was not difficult. This is C. diff. That complication of pseudomembranous colitis has been known to occur as a complication of antibiotics since 1950s. When the antibiotics hit the medicine, that's when this complication happened. And it was occasional. This particular version of it has a high mortality. It wasn't associated with C. difficile until 1970s. It was thought to be staphylococcal infection before that. Its precise definition didn't really, or identification didn't matter because there was an antibiotic called vancomycin that came out around the same time, and it covered staph and it covers C. difficile to this day. So that was the standard treatment. However, in this case, the standard treatment was failing. She had a number of courses of vancomycin. Didn't really reverse this. So what people have done in the past, back in the 1950s still, is take stool from a healthy donor and try to fix the microbiome. There was little insight what that achieves, but they had a basic inkling. And actually, I touched base with the true pioneer of that back from 1950s, Dr. Eisman, who at the time of my contact was in his 90s. And he said, yeah, back in those days, we thought the antibiotics were killing some healthy microbes and we needed to put them back. He also remarked that at that time, there was no IRB and there was little regulation to think about. So if you had a good idea, you just did it. So he did it and actually made it somewhat of a splash back then. And Dr. Wangenstein in this institution was then doing the same thing back in the early 1960s. And then vancomycin kind of took care of things for a couple of decades. But as you can imagine, microbes don't just sit back and watch and give up, they evolve. And so over past couple of decades, this problem started coming back and more difficult cases started emerging. The C. diff infection became more virulent, more mortality, more morbidity. And one big problem, which is illustrated to an extent with this patient, is this recurrent infection. You can wrestle it down with antibiotics temporarily. You stop the antibiotics, it springs back. The reason is antibiotics don't kill spores. And in fact, if you really, that's still a hypothesis, within these pseudomembranes, and there are probably biofilms that are very good at hiding microbes from and protecting them from antibiotics. So there's different ways for it to hide. And so we did this. This is basically the cycle. Every time, this is the overview at a Mount Everest height of C. diff pathophysiology. The way the digestive tract is put together in humans, we're hindgut fermenters. That is, all mammals have a microbial organ that participates in digestion. And foregut fermenters like cows, that is upfront, and it's the major way to ferment food and get calories. In humans and many other mammals, we're hindgut fermenters. The microbes finish the digestive process, and that's in the colon. So that's a place where we have the densest microbial community. It's part of the digestive system. And these microbes are adapted to the human host and important in it and to all kinds of aspects of physiology. Anytime you take antibiotics, it's like you throw a grenade in there. That microbial community becomes disrupted, and for a period of time, there's vulnerability to invaders, because one of the functions is colonization resistance against pathogens. C. diff is one of those. Once that establishes residence in your colon, that's its natural home, in fact, because it evolved from innocuous bacterium, C. difficile, that lived in the colon and started making toxins, acquired a different lifestyle. So once it's there, it starts and it sees opportunity. There's like a suppressed microbial community. So it sees opportunity to cause trouble, makes toxins, and makes more spores, causes disease. We treat that with antibiotics. As I just said, could be it's not going to be sufficient, and you're going to see a relapse of the infection, and you treat it again. And these recurrent cycles happen with every time it happens, you have to add 20% chance it's going to happen again. So first time around, 20% chance of recurrence. Second time, 40, 60, and then it's just not going away. So the solution, that's back in 1950s, was to put normal microbes back. And actually that's known to work clinically. So that's the That's the patient I had at the time. Thought we would do it. But being somewhat of a scientist, I thought one thing that's never been done is actually what does happen when you do that? Do you see an engraftment of donor bacteria, or what exactly happens? In fact, at the time, the paradigm was you cannot really change somebody's microbial community. It's like established. You have the indigenous flora that is unmovable. So I collaborated with Dr. Michael Sadowski in soil science to do this simple experiment. Take some samples from the donor, happened to be her husband, the patient before, and then after. And this was our result. So this is somewhat prehistoric days. This is published in 2010, and the assay is TRFLP. So we do a digest of the microbial community, and then you see essentially a barcode of different size of fragments. You pick on these fragments and you compare it with a library of clones that you have to get some kind of taxonomy. But what you see here is this is the patient sample before. You can ignore this one. This is a washout during colonoscopy, which is the way I was putting a material in. It looks a little different. This middle one is her husband. And then 2 weeks later, this is the patient. And then this is a month later. So this figure really was a birthday of sorts of this entire field, because it was the first time anybody did any kind of science on poop of this, in a clinical setting as an intervention. It made quite a splash. The New York Times came, 2010, was on front page. And based on this result of one patient, I actually renamed this procedure, which was known as biotherapy, to a fecal microbiota transplant. Because, there's engraftment of donor cells, so that's a transplant. What are we engrafting? Microbial community, that's called microbiota. There was actually a meeting of us physicians at that time trying to come up with a name. I didn't like the word fecal. I thought this is going to be a killer, not in a good way, of fundraising and talking to patients, and I got overruled. So they insisted it comes from feces, so it's fecal. And then the next thing that happened is everybody cut out the word microbiota because it's too complicated. And it became a fecal transplant, which is even worse. And from then on, I tried to fight this and failed. You cannot control language. Once it gets out there, it has a life of its own. And it's been picked up by industry to make fun of it, etc. So that's the story of the fecal transplant. That may have been a kind of a birthday, but really the much more impactful paper was this back in 2012, which again we did with Mike Sadowski in collaboration, which was a method to purify the microbes away from stool. Because the first case, and the first 10 cases or so that I did, I would just throw a turd into a blender and homogenize it and put it in a syringe and put it in. As you can imagine, that's not easily adaptable to mainstream medicine. Few physicians are going to do that. In fact, probably some environmental controls would have problems with it legitimately. So this is what we came up with, is through a series of filtration and centrifugation steps, we would purify the microbes and then importantly, freeze them with glycerol, the entire microbial community. Then you can package it and you put it in the bank. And then it can stay there frozen and you can do more testing on the donor. That became really the critical part for the FDA to say, okay, this is somewhat legitimate, because you can really do testing on the donor even after the donation, because they were concerned, well, what if the donor, this is the kind of stuff the FDA thinks through, on the day of donation, contracted HIV. How are you going to know? Well, you have to test afterwards. So they really, for them, that was really important step. So this paper, within a month, stool banks popped up all over the world, including the United States. There was a nonprofit that opened up a month later called Open Biome, which then over the subsequent decade was able to treat about 75,000 people. The FDA, of course, took notice of this activity and said, okay, you know what? Anything that's used to cure, treat, mitigate, or prevent a disease is called a drug. And this is a drug and a biologic product. And more than that, it is an unapproved drug. And in order for you to use an unapproved drug, you have to have an investigational new drug application that has to be approved by the FDA. And so there. And not showing you our application, but I did weigh it at the time on a scale because it was in paper. It was 24 pounds. You can imagine that the physician is not going to write an application that fits in 2 boxes to treat a patient. So there was a big uproar at the time. This is 2013. This was May. In July, they came up with a little adjustment called the enforcement discretion. The government can choose which laws to enforce and which not. This is like a gays in military, don't ask, don't tell kind of thing. So they came out with this policy of enforcement discretion. As long as you're treating C. diff infection that's not responding to standard antibiotics, you can do this, and there's no regulation required at all. And that was the case, which is why Open Biome was able to treat that many patients over a decade, until November of 2022. And what happened then is, I'll go to that. We had an emergence of a commercial product. Rebiota was the first one. Also, completely based on our work, as confirmed by a jury trial in August of 24. However that may be, we had a lot of interactions with the FDA, and the message was from the FDA. It was very interesting and very educational for me. They basically said, not so many words, that one of the missions of the FDA is to protect the interests of drug companies. It's not what it says on their website. It says safety efficacy. But they have a third mission. It's pretty clear that they were threatened by Ferring Pharmaceuticals, which is what Rebiota was, and probably in some disclosure when all the dust clears from all these lawsuits. I guess I could be getting some royalties at a certain point, but they're still debating of the exact amounts. What I'd rather talk about is, and in fact, the United States is the only country that has determined that this is a drug paradigm. There's different regulatory frameworks in different countries. In Europe, it is closer to blood banks. That is their law. Why is it a drug here? Because the way the law is written, anything that is, as I said, used to cure, treat, mitigate, prevent disease is a drug. Well, what about transplants? Well, those are accepted because those are human cell tissue. So in fact, the law says, except for human cell tissue transplants. And this material, FDA said, is not human. Therefore, the only other pathway is a drug. In Europe, it says substances of human origin. So they didn't think it through that the future would be poop, but that's how it turned out to be. And so the regulatory paradigm there is closer to blood banks. In Australia, they carved out an entire new category altogether. How much does it matter? I kind of fought that as well in academic papers, which the FDA doesn't care about for sure. Because I argued, well, these are not any microbiota. We're not taking this from like a dog. These are human microbiota. These are human microbes that adapted to the human host. And therefore, they're part of the human body. Yeah, whatever. Bottom line is I've actually embraced this paradigm since, and I'll explain why. So what this is basically a new branch of pharmacology, and I asked this directly from the FDA person as well. As like, well, okay, if it's a drug, then it has a pharmacology. So what is the pharmacology here? What is the pharmacokinetics? What are your thoughts on identifying PK, PD, and all those things? And they said, yeah, it's for you to figure out. Okay. So it is somewhat different from the usual drugs in many ways, not just because it's live microorganisms, but because of the area that we're targeting. We're targeting an area that is an open system. It is actually a fairly complex space. There's luminal microbes. There's microbes that are adherent to the lining. There's even differences between crypt and villus microbes, and certainly differences between colon and small bowel. So that's a big difference. And then there's all these modifiers that happen. I mean, a lifestyle has a huge impact on what happens in this open space, much more so than anywhere else. So we have to think somewhat differently about it. Nevertheless, the same basic components of pharmacology still apply. So what we have pharmacy, we have pharmacokinetics, pharmacodynamics, pharmacotherapeutics. So I'll just go through that. Pharmacy is how do you formulate the drug? And there's many different ways here. You extract the microbes. How are you freezing them? Are you going to put them in a capsule? What's the capsule release characteristics? Is it a liquid formulation, et cetera? All of that is not just pharmacy that counting pills at the counter. This is actual science of pharmacy. Pharmacokinetics is what happens to the drug in the body. Pharmacodynamics is what happens to the body because of the drug. So it's closer to mechanism. If you understand all that, you can put it together into pharmacotherapeutics. That's what the physician is supposed to know, which they rarely do. Then we have to think about toxicity. Like, there could be some pathogens, for example, in there in your prep. And that has happened in case reports. You probably should be thinking about drug-drug interactions. So what if your patient is a heart transplant recipient? And we know the microbiome does participate in drug metabolism. So what happens when you suddenly change the entire composition? Should you be monitoring drug levels? Or maybe a more common thing like warfarin, which is known to be microbial dependent. So a little bit about pharmacy. So this is the evolution of our product development. It's already outdated. So back in 2010, when we just homogenized stool and put it through an initial filter, it was just fresh homogenate that was used. Then, as I said, we learned to freeze it, and that became the workhorse over the subsequent decade. It's basically, you can just store them at -80. The clinical provider can request a unit from Open Biome or wherever, and they would get it into pharmacy, thaw, ready to go. In 2015, we developed a capsule preparation, so it's freeze dried. And so what's in this little vial is, that's all you need for that to treat one patient with recurrent C. diff infections. 2018, you see major advance. We colored the capsules. Now they're Swedish orange color. Most recently, we actually went to a new formulation for some of the applications, and that's just powder that you can suspend in whatever carrier. And that's because some of the indications were for pediatric studies, and kids were not able to swallow capsules. So we got it purified to a point where it has no taste or smell. You can just drink it. Our institution is, or we're fortunate in that the University of Minnesota has a GMP facility. There's not many academic institutions that have that, but that's basically operating according to pharmaceutical standards. So there is a quality assurance program there, and quality control. And there's multiple academic units operating there, some making small molecule drugs, some are making things like pancreatic islets. What this GMP production ensures is that whatever your manufacturing process is, it is strictly adhering to the protocol such that every lot is made the same way. You could say, well, every donation that you get is somewhat different. That's true, but at least the manufacturing part is identical. And then there are the QA reviews all the clinical data, as well as all your manufacturing data before material is released into, could be clinical use or clinical trials. The basic paradigm of manufacturing flow is summarized here. So there's initial screening, and we basically set out, why did we need this standardized way of manufacturing? Really, the first problem came up with, like, who is the donor? And that's the question that is asked by most patients. Like, who are these donors? So when we first started, the first case was patient's husband, who happened to be a very healthy individual. They've been married for 40 plus years. And it's like, what can we possibly transfer that's new that they haven't shared already? So that worked out. But then the next patients came and like, here's my donor husband, and he's 300 pounds, and he had gastric bypass, and he has diabetes. And I'm thinking, okay, what disease could I be transferring here? Because microbiome is important potentially into all kinds of disease processes. So after doing like 10 cases like that, I said, no, we can't do that. We have to take responsibility of our donor selection. And we established a donor program with the premise, we should be able to find healthy people even in America. Indeed, as other stool banks published around the world, their success rate in finding truly healthy people is like 1%. Part of it is the strategy of how you look for donors. So we tried things like putting posters up, and that is a bad strategy. People are just, who respond to that, think they have fascinating poop, and that's what we're interested in. Like, we're definitely not interested in anything that's fascinating for this indication. Anyway, so we do initial screening, and we actually make it difficult because we want to look for people who are truly committed. And then you go through inclusion-exclusion criteria that weeds out a lot of people. That's not the end of it, because once they go into production, there's release criteria that is after the manufacturing, as I said. And there is certainly a lot of know-how in how to run this kind of a donor program. It's not easy to be a donor because people have to donate in a supervised bathroom. It just can't just bring poop from outside. I'm like, here, that's a chain of custody violation. The FDA wouldn't like that. So there's logistic concerns that are not trivial for people to be able to do that. And most of our work now is not for C. diff, and that creates a different kind of manufacturing requirements. So the donors really have to be, when they are on deck, they have to be coming in every day for several weeks in a row. So this has been one of the next areas of contention with the regulators at a federal level, because they really haven't thought through this. So, okay, it's a drug, still a transplant, still dealing with donors, and it's still something that the patients legitimately are most concerned about. And you're dealing with a waste product. And no matter how much testing you do, and we do a lot, there's still an element of trust, a trust that's implied by the FDA itself. When monkeypox, for example, came out, they were struggling with that for a couple of months, and then came out with an idiotic questionnaire that we have to ask several times a week, like about donors attending gay bathhouses, things like that. So as silly as that may be, but you still have to have trust there. And as I mentioned, for blood donation, people can donate several times a year. Here, it's a very intensive participation. So to the extent that you have to start thinking about reimbursement and how much is your nominal reimbursement is for the expense of coming and committing your time and just saying a little bit of a thank you, versus it's a job and you don't want it to be a job. And then there's another problem, because you're doing a lot of testing, there are going to be abnormal results. And these are human beings, and you have to somehow deal with the abnormal results too. Those are ethical issues. So we are overseen by IRB. We recognize that our donors are really our critical partners. Recognize this moral hazard of monetary compensation. So we ran focus groups with the donors, like, well, given the level of the intensity of what we're asking, it's just proven that no matter how good altruistic people are, it's just not feasible not to pay anything, especially when you're asking them to come in the middle of winter to your bathroom. So they told us $20 a visit. That's where we are. And one time, for example, well, anyway, this is a commercial product now, not ours, but there's a company that came up with it. And as soon as they came up with it, and this is in Twin Cities, and that's not an accident. This was one of the first things that happened, is their donor program became active, and these ads were blanketing St. Paul. This was from a urinal at the university, advertising $500 a month, basically just money. The comment from Reddit: "It's a dream come true, fellas. You'll now be getting paid for poop." The latest, as of 2023, reimbursement from them was $1,600 a month. They don't have to operate with IRB or anything, and it's just completely blind to the FDA. So that's one aspect that is, I think, still very much an area of concern. Europeans have their own way of looking at this more stringently. They're leaning more toward the blood banking model, and there's payment is just not allowed. So they may be constrained somewhat depending on the indications. So back to pharmacokinetics. In pharmacokinetics, we have the ADME parameters: absorption, distribution, metabolism, excretion. This kind of second year of medical school. So how does this apply to this field? And I thought, well, kind of applies. Maybe it's a bit of a stretch, but there's an administration route. Could go from below, could go from above. There's definitely a distribution question. So all we're sampling in vast majority of studies is the stool itself, which is a kind of a distorted window on what's happening inside the GI tract. Because as I mentioned, there are different ecological niches there. Maybe the luminal microbes are important in some diseases more so than the mucosa adherent. It could be the other way around. We're just sampling whatever comes out, and that's biased toward luminal microbes in the colon. And so to really study distribution, you have to go inside and you have to sample different parts, which is invasive and difficult. Then there's the whole computational technology of how do you even look at microbiome change. Microbiome, so there's different techniques to measure engraftment, different metrics to just describe the microbiome. There's, aside from bacteria, you also have bacteriophage, you also have fungi, protozoa. All of that easily gets as complicated as you want. So that is a wide open frontier as well. A common question is, well, why do you need all these microbes? Why can't you just have a couple important ones, figure out that, and just use that? And in fact, some companies are following that. But this is an example of what is happening in C. diff. This is 2014. So it's a primitive network, but microbial communities are networks. They're organized. The different microbes are interacting with each other. What this is, different lines here, green and red, are indicating the green ones are positive associations. So when you have these two bugs repeatedly and from sample to sample, they seem to go together. There's probably a positive association there. If there's and a red line means they are opposing each other. So this is a C. diff patient. So first of all, there's a lot of fewer microbes left. And then it seems like most of them hate each other. Kind of think of it like a human society. To run a healthy human society has all kinds of people. You know, mechanics and hairdressers and maybe a couple of doctors, a couple of lawyers and stuff. And this is what happens when all you got is lawyers and everybody else is gone. And the FMT does recover this very quickly. The entire community springs back to normal. It is my bias that it's very difficult to achieve that with a couple microbes. Basically, this will happen. You may be able to find the critical microbes, especially important for C. diff. But then the rest will happen on its own because you're not living in a germ-free bubble. It's just the microbial community is going to assemble what is needed from the environment, just like a baby when it's born. It takes 2-3 years and people build a microbial community. Babies crawl on the floor and put things in their mouth. And maybe that's what patients should be doing, but it depends on where it is. And if they're in a hospital, you don't want to be doing that. So we did the most pharmacokinetics, if you will, with this capsule product. And basically we learned that it takes about 3 weeks for the microbial community to hit a plateau where the diversity doesn't go any higher and pretty much everything is set. The donor microbial, let's see, this is Shannon diversity index here, these black dots. It always is higher than in the patients. And we're kind of working on that. It's possible, for example, that in the process of purification, we're still killing some microbes and maybe not really transferring the totally full spectrum. That is a concern that I have. Or there's something about these patients that are just not able to maintain a fully diverse community, or the diet is a big factor. And the donors, as you can imagine, people who can poop every day on demand probably have a healthy diet, and they do. And most recipients don't. So could be that. But the patients do ask an important question. It's like, well, okay, so you gave me an inoculum of microbes. How do I keep it healthy? Those are questions that yet to be really explored. With probably having a diverse diet that has many different vegetables and sources of fiber, diverse sources of fiber, is probably good for the microbial diversity, because that's what microbes like to feast on, is leftovers. And we're not very good at digesting fiber material with our human enzymes. So that's kind of microbial territory. That's hypothesis yet to be tested. Dan Knights, who's done really a lot of work in setting up computational analysis for us, even before he came here, did some experiments with fiber, feeding his class a fiber supplement, and actually showed if you feed one kind of fiber, you don't necessarily get a great diversity. You may be preferring a particular group of microbes that really benefits from that, and then they elbow the other ones out, and you can actually have a contraction of diversity, even though good things can be made. So there's a lot in this area as well. As far as pharmacodynamics, we're dealing with probably arguably the simplest problem, and yet it's so complicated, the C. diff. How does that actually work? So is it because all these new microbes are taking away food from C. diff? Basically competitive niche exclusion, or something else. So early on, we've demonstrated that bile acid metabolism is very important for C. diff. These bacteria, one way they sense their environment is they measure bile acid chemistry. So your liver makes primary bile acids. They're important for digesting fats and such. And then when they reach the terminal ileum, end of small bowel, they get reabsorbed back, but small and recycled. About 95% is recycled every day. 5% gets in the colon, and the microbes will graze on whatever they can, and it becomes secondary bile acids. So C. diff is able to sense this chemistry. When there's microbes gone that are doing secondary bile acid metabolism, it knows there's an opportunity here, and that's a signal for germination and vegetative growth. So if you can, what rapidly happens with FMT is secondary bile acid metabolism is restored, and that keeps C. diff in check. But there's other mechanisms. So microbes kill each other with bacteriocins. There's indole metabolites that play, and short-chain fatty acids that play a role. There's some element of host immunity that could be important. People even postulated, well, maybe it's not bacteria at all. Maybe it's the phage that comes with them and just kills C. diff or something. It's probably not true, but it's a viable hypothesis and something else we haven't thought of. And what we discussed with C. diff is really prevention of another relapse. So you treat the patient with vancomycin, keep that C. diff suppressed, and then in a very narrow window of time, you stop the vancomycin and you give new microbes. And that works about 90% of the time to prevent another episode. Sometimes patients come in the hospital and they're really sick, and that's what their colon looks like, and it's just covered with pseudomembranes. That is a different beast. And I think it's actually kind of related to sepsis. And what happens in this condition is, well, they display all the clinical signs of sepsis. The blood pressure is down, there's organ dysfunction, white count is way up. And probably what happens is there's enough of a break in the gut barrier that you have leakage of microbial products that are driving the septic syndrome. And some kind of magic happens if you infuse the microbes in that setting, that you see a rapid improvement in septic parameters. I don't know if it must be some anti-inflammatory signal that is able to happen, but it's really unstudied, but a definite thing that happens. So being that we are ended up with our GMP production facility, really the only academic group in the country that manufactures these products in pharmaceutical standards, we've been approached by multiple groups around the country and some of the EU to do clinical trials in all kinds of indications. And that's kind of where most of the interest is these days. So those vary from inflammatory bowel disease, as you can imagine, like Crohn's and ulcerative colitis, where there is a basic understanding that there's something off with the immune system going, triggering in inflammatory responses, but against what? Probably something wrong with the microbial community. So all the therapeutics today are immunosuppressive, but there's perhaps interest in, well, what about the microbial side of the equation? We have a collaboration, just as an example, with food allergies in Boston children, because of the prior work showing that this procedure has some kind of immunomodulatory effect. Related to that is cancer therapies. There is a number of papers now showing that, first of all, the state of the microbiome is relevant to how well somebody's going to respond to checkpoint immunotherapy. If somebody is going to be on antibiotics right before, correlates with less optimal result. And the dark side of checkpoint immunotherapy is complications like colitis. And that also seems to be responding to FMT approaches. So we have this interest in the solid tumor area. In the bone marrow transplant, somewhat different problem, maybe closer to C. diff, in that those patients get bombarded with antibiotics because their immune system is down due to chemotherapy. On top of that, the gut barrier is disrupted by chemotherapy. The microbes that remain are not the friendliest types. That's what happens when you create a hostile environment. The microbes do acquire or show more virulence factors and more antibiotic resistance. And then you're trying to develop to nurture a new immune system in the setting of all this hostility. And so the idea is, well, if you normalize the gut microbiome quickly, maybe you can mitigate or prevent graft versus host disease. And maybe you can cut down on some of the infectious complications. So that's that idea. There's, problem of rising antibiotic resistance, and the gut is a reservoir of antibiotic resistance genes. It is basically an ideal environment for horizontal gene transfer because of the density of microbes, as well as things like biofilm formation, which facilitate contact and gene exchange. And so if you look at sick people, they're full of scary looking things in their gut. Depending on how good the barrier is, they may or may not be suffering the consequences. But it is kind of like a climate change tsunami wave that's coming to medicine. And it's estimated in another decade or so, we may be looking at infections with antibiotic resistant organisms are causing more deaths than cancer, unless we're doing something about it. So this is one of the ideas of somehow decreasing the burden of these kinds of microbes. et cetera. So some of the extreme indications, as an example, is autism. So could that work? And I thought, that's just crazy, but that's actually been one of the more productive areas of research. And cutting to the some kind of hypothesis, if you actually measure urine metabolites, microbial urine metabolites in patients with autism versus typically developing children, you can, at this point, tell them apart without looking at the patient with 90% confidence so far. So there is some component in the gut that may be contributing to these symptoms. And some of them are like paracresol, for example, a tyrosine metabolite. If you feed that to mice, they become behaviorally weird. So it's not like a completely crazy idea, but if you can somehow restructure their microbiome, maybe you can mitigate some of these behavioral as well as GI symptoms. And so far, we've done 3 phase 2 trials, and indeed, there is some positive effect. So it's microbiota transplant therapy. I finally because it's in our control, was able to get rid of the F word. And it is kind of a therapy, and there's an antibiotic conditioning steps. Because actually, if the original idea that you can't change somebody's microbiome easily, that's true. You can consume our products and nothing will happen. You need to throw some grenades in, or you have to consume them a lot. So like if you do mouse experiments, you put the mice together in a cage and they eat each other's poop for about 3 weeks, and then you have some kind of equilibration. So a one-time poop eating is not going to do anything. So you either condition with antibiotics or do a lot of this. And in order to restructure the microbiome in these kids, it's actually both. They do get the 2 weeks of vancomycin, and then they get a couple months of this therapy with capsules. And it does have, there's the protocol. And there is improvement. If you look at both behavioral and GI symptoms, everything does get better on average. Obviously, we're clashing. It's like a super collider where we're clashing the most complex biologic systems you could come up with together. There's a microbiome clash. There's immune effects that we don't understand. And then there is a central nervous system. To try to tease out mechanisms there is going to be difficult. As another example, and this is kind of where the field is moving, for C. diff, any donor will do. And I thought for bone marrow transplant, the same may be true because it's very similar, but this just got published by our former colleague here at the university who went to Fred Hutchins. And he ran a little Olympics, different donors in the bone marrow transplant setting, trying to pick the best donor for his randomized controlled trial. And there was a clear winner, enough to get him a Nature Communications paper, in that this particular winner had the best engraftment and the fewest events of graft versus host disease. And microbial community was characterized by a very large proportion of this organisms of Bifidobacterium adelensis. So going forward, trying to kind of generalize this, we could be looking at the microbiome tests and trying to select a particular pattern for a particular indication. So moving forward, this is, by the way, from the standpoint of the FDA, all these products are called live biotherapeutic products. They don't care about FMT. The work is improve or work on different formulations. How do you extract microbes? This is also an industrial engineering question when you start going on a bigger scale. It's fine to do little trials, but you can imagine if 1% of children have autism and you have to do this kind of protocol for that many people, you have to start thinking of how we're going to increase the numbers. Encapsulation technology, where these microbes are released, is an interesting question. For example, in some of the immune modulation trials, the hypothesis is that maybe you have to tickle somewhere in the small intestine with immune receptors rather than change the colon microbial community as the main target. So the release may be important. And of course, really moving toward personalized medicine and using microbiome and metabolome assays to select donors for individual indications. There's a lot of work on optimizing dosing regimens, looking at engraftment and clinical benefits, and really understanding the mechanisms. So that leaves 3 minutes for questions.
Yeah, so you kind of alluded to this when you talked about phages possibly having a role, and I know you're skeptical, but I was curious if the preparation itself, if you move from whole matter fecal to purified microbiota, if you think that there's, what your opinion on potentially losing some benefit, if there's any kind of cofactors or other beneficial material that might be in there for the engraftment that we might be losing.
Yeah, so the efficacy didn't really go down when we went from just the quick homogenate down to increasingly purified products for C. diff. It doesn't mean that in other applications you might be losing something. I'm not dismissing phage completely. So our prep is essentially a bacterial prep. It's quite clean. But then we did track phage. So you can still identify prophage in your bacteria in the donor. And then what we saw is that some phage does stay very faithfully associated with the donor microbe, but others go and find new hosts across taxonomic ranges. So there's clearly some transfer of bacteriophage even with our bacterial prep. Relatively little work done in this area because it's more intensive. People have, there was a trial in Canada where they did a fecal filtrate such that they were filtering bacteria out. So they were trying to collect what they thought was mostly phage and see if that has a therapeutic effect on its own, and it did not.
Very informative presentations. I'm wondering, does the genetics of an individual, does the FMT depends upon the individual genetics? Like suppose some individual will show more success to the FMT, it depends upon the genetics or not. Like as you show that like the metabolites from the microbes affect us. Does there any other things which affect the microbes as well? Does the genetics modulate those things? And my second question is that how you guys protect the anaerobic microbes during the transfer? Like is they are almost killed, or you guys have specific instrument to protect those oxygen sensitive microbes? Thank you.
So first question kind of deals with how much variation there is in the donor and perhaps recipient, and we're going to get different effects. So it probably depends on the indication. Well, I know it depends. For C. diff, which was the foundational indication, it doesn't seem to matter. Like there is no bad donor. Really, we haven't tested sick donors, but any healthy donor works fine. Dose may matter, but not donor selection. And dose we define in number of organisms. For other indications, I'm pretty sure the donor selection matters.
The genetics of the receiver, like
Recipient. Yeah. So again, so there is an elite couple patients I can think of. So I've treated about 1,000 people. Of those, there's a couple that just would not get cured with this. What exactly was the mechanism in them? I never figured out. But that's C. diff. So the vast majority do just fine. The main problem is if they take antibiotic again for something, they're still at high risk of waking up their C. diff. In other indications, let's say I give you an example. Another recently published study with our work is hepatic encephalopathy. So in that disease, the liver is scarred down. And so there's toxic metabolites accumulating in the body that cause effects on the brain. And in the most severe form, people just fall into coma. The standard treatment for that is giving a compound called lactulose, which is food for microbes. How that works is not totally agreed upon. Classically, it's taught microbes will consume lactulose, the pH in the stool will go down, that will trap ammonia into ammonium, and that's toxic to the brain, and you poop it out. That's one mechanism. Well, so in this trial, all patients were on lactulose. And FMT had an added effect in protecting them against hepatic encephalopathy. So I thought, well, in that case, maybe what it's really depending on without FMT, the lactulose effect depends on the ability to utilize lactulose. And if the microbial community is so decreased in diversity and you can't utilize lactulose as well, you're probably going to be the one most appropriate for this therapy to give you the microbes that can actually use it. So that could be a role for selecting the best recipients for this therapy if you really understand the mechanism. Same maybe in autism. Maybe if you run the urinary metabolites and you see, this is really a big signal for some microbial change, and we need to pick a donor. We don't want to give a donor with the same things. Pick a donor that's opposite. So that could be a way to personalize this therapy. And I think that's really where most of the work is going, is really understanding the mechanism so you can restructure the microbiomes in the way that is therapeutic, and both on recipient and donor side. An alternative way that people are thinking is we're going to be so smart, we're going to construct synthetic communities based on our understanding of mechanisms. I just think it's not happening in my lifetime. So we're going from natural communities and trying to stratify them.
All right, well, let's give one more round of applause for a great talk. Thank you.